respected for the time. Okay, so a formal welcome to all of you. And today it is a little different kind of, session with a lot of cases and a quiz at the end to test all of you. And today we have with us Dr. Arif Mustaqim, who is the General Secretary of the Delhi NCR branch of Indian Academy of Echocardiography. And the other faculty with us is Mrs. Sangeeta Podwal from Ruby Hall, Pune. And she's also, you all know that she's a very learned personality. And so we have a very good basket of interesting cases. And keep getting involved and interact with us. You have any suggestions or you have any questions, do let us know. And Dr. Arif, can we ask Dr. Sangeeta to start first?
Yes, ma'am.
Huh? Okay,
Yes.
Sangeeta, can you start sharing your slides? Hello, Reena.
Ma'am, good evening, good evening.
Thank you so much. This time I disturbed you at the very, very last minute.
No, ma'am, I am available 24/7.
Yeah, that's your greatness. That's your greatness. But it was too instant and, I expected
It's
everything,
okay,
in
it's
the
okay,
last
ma'am.
moment.
It's okay.
Thank you so much.
Thank you, ma'am. Thank you.
Sangeeta, are you able to?
Yes, ma'am, I'm ready now.
No, but we are not able to. We are not able to see your slides. You can
Shall
share.
I share the screen?
Yes, please go ahead. Go ahead.
Ma'am, can you see the screen?
Yeah, we can see the screen, but we are not able to see your slides.
Okay.
Not yet.
Ma'am, can you see now?
No, we can see your screen, but not the slides.
Hello?
Sangeeta, share your presentation. Your desktop is visible, but your slides are not visible. Yeah.
Yes.
Just zoom it up. Enlarge the screen, Sangeeta. Yes.
Good.
Now it's okay.
Can you see? Yeah, can you see now?
Yes, absolutely.
You can see now?
Yes, Sangeeta, go ahead. You're visible.
Okay.
Well, yes.
So shall I start, ma'am?
Yes, please go ahead.
Okay, so we'll start with the some interesting cases today. And I have two actually simple cases. Looks to be simple, but then as a echocardiographer, you have to really do them carefully and then for your diagnosis. So my first case, it's of a 70-year-old male, came with an acute onset breathlessness, functional
audio is not good.
3 on admission. There was no prior long-standing history of any heart valvular audio. You can hear me now, ma'am?
Now it's better. Otherwise, it was
Can you hear me
breaking
now?
a lot. Some internet connection.
Okay.
Problem.
Yeah, my connection is not that better today. I don't know. Something is wrong. Can you hear me now, ma'am?
It's better. Now you're
Abhi sun rahe
audible.
hain? Okay.
ठीक है. You go ahead.
So this case, first case, is of a 70-year-old male who came with acute onset breathlessness, functional class 3 on admission. There was no prior long-standing history of any heart problem. No any history of rheumatic fever or any chronic valvular heart disease or prior ischemic heart disease. No fever or any other known comorbidities. In examination, his ECG had atrial fibrillation with fast ventricular rate. Chest X-ray showed pulmonary edema and prominent pulmonary venous congestion. There was soft systolic murmur, no cardiomegaly on X-ray. So we'll start with just a four-chamber view. So you can see the left ventricular functions quite normal, and mitral valve, actually there is significant mitral regurgitation. So that was what was actually seen. I could record only some views because this patient was quite dyspneic. Now you can see the posterior mitral leaflet prolapsing into the LA. At the tip of the posterior mitral leaflet, there was very tiny shadows seen. So actually the diagnosis started whether this was a vegetation or whether it was a ruptured chordae. So that's how it started. So if you see carefully at the tip, you see very tiny vegetation-like structures. A minimal aortic regurgitation also is present, but that is just related to the sclerotic aortic valve. If you see on the TR is there and the significant pulmonary hypertension was there. See, the velocity is around 4. So that means the pulmonary artery pressure was more than 70. That's the tricuspid regurgitation, which is 62. So around 72 was the PA pressure, RV systolic pressure. So significant pulmonary hypertension as well. So now the dilemma was whether this patient is having vegetations or whether it is something else. Something else means you have to think of chordal rupture. So if you see here, the posterior mitral leaflet is quite, flail. It is coming in the LA. And at the tip, there is something which was not really seen properly. So we had to take this patient for transesophageal echocardiography. Now, this is a transesophageal echo of this patient. So you can see this structure here. And here, very clearly, if you see, this collapsing structure is there, and this appeared to be a chordal rupture. See the chord here. So very nicely seen. Actually, if the vegetations are there, there was definitely a dilemma, like whether this is vegetation or whether this is chordal rupture. And someone has to really, when you're doing echocardiography, you have to be very careful. Now, this spontaneous vena contracta itself shows that there is significant mitral regurgitation, and that is why there's a lot of pulmonary hypertension also. So we'll go to the next slide. Now, 2D echo findings showed flail mitral leaflet. There was a ruptured chordae or query vegetation. Of course, vegetation or chordal rupture, more of a clinical finding. Then severe mitral regurgitation, hyperdynamic LV, and non-dilated LA that actually suggests that this MR is acute. So findings of acute MR are sudden volume over, because of the sudden volume overload of LA. LA is not dilated, and that's why the pressures will rise rapidly. And that's why you will find acute pulmonary edema and rapid development of pulmonary hypertension. In elderly patients, most common cause is usually this degenerative mitral valve disease, like myxomatous degeneration. You can have a post-MI papillary muscle dysfunction as well. But for this patient, if you see, there was no segmental wall motion abnormality. Infective endocarditis had to be ruled out, and severe MR can be found if there is another trauma also. So in acute, what you see in echo is, like, suppose there is acute MR, usually the chamber dimensions will be normal. And in chronic MR, you will get a volume overloaded, like left LALV will be dilated. And in acute MRs, you will definitely have severe pulmonary hypertension because the LA size is small. And in chronic MR, usually pH is not there. I mean, it progressively increases. So the preoperative preparation of this patient was, we had to rule out whether this is infective endocarditis. So we did a blood culture and of course transesophageal, and blood culture of this patient was negative. So if we ruled out that there was no vegetation, there was no endocarditis. So second step was stabilizing the patient's hemodynamic, because in such patients you sometimes require IABP. But as this patient did not require IABP, so the management was like, this acute severe MR becomes a surgical emergency. So patient underwent mitral valve replacement. She was done a bioprosthetic valve. So intraoperatively, no vegetations was detected on by the surgeon. Valve was sent for pathological examination. And in this elderly patient, of course, you use a bioprosthetic valve is preferred, because it avoids long-term anticoagulation, and acceptable durability is 10 to 15 years. So the take-home message is, echocardiography is an important tool to diagnose acute versus chronic MR, and early diagnosis definitely will help the patient management. Thank you.
All right. Thank you, Sangeeta. Acha, do you have any Doppler trace of the MR?
No, ma'am, not really.
Hmm?
But then that's what I just mentioned, that you see a spontaneous vena contracta. I think that is enough to say that this MR is significant. And on 2D, it was not very well seen, but on transesophageal, if you saw, there was significant MR, which was nearly occupying whole of the left atrium.
So, Dr. Arif, any
We did take
comments?
the we did take the ERO and all those things. The ERO was, around more than 6 or something. The volume also was very significant.
No, I think it is quite clear. Otherwise, I could not see much. The window wasn't very good because it must be an acutely unstable patient. So, but yes,
Yeah.
on transesophageal, yes, some chordae, ruptured chordae, and the prolapsing valve was seen. Okay,
Yeah.
so there are 2-3 things which I would like to tell the audience, that if there is a flail leaflet due to caudal rupture or papillary muscle rupture, you can very well see, and it's like a very uh, violent type of MR, because the whole papillary muscle gets avulsed due to trauma or myocardial infarction. But in caudal rupture, there may be few chordae which gets ruptured, and that particular valve starts prolapsing and falling back in the left atrium. All right. So what happens is that you can very well clearly see that particular valve prolapsing and an eccentric jet. Because if the posterior leaflet prolapses, where is the jet going to be directed? Can someone prompt? Unmute and prompt. Posterior valve prolapse.
Anterior direction.
Pardon? If the posterior mitral valve prolapses, where will the jet is going to be eccentric? So where is going the jet directed towards?
Towards the septum.
Anterior.
Intra-atrial septum.
Very good.
Anteriorly.
Anteriorly,
yes.
right? And when it is the anterior mitral leaflet which prolapses, where will the jet directed?
Posteriorly.
Posteriorly.
Okay, so
Posterior.
whenever you get these kind of eccentric jets, start thinking in your mind that is it something to do with a particular valve, dysfunction? All right, because otherwise the functional MRs are all central jets. So any eccentric jet should direct your mind towards an individual valve pathology, meaning a leaflet pathology. All right. And as Dr. Sangeeta has emphasized, in acute MRs, the LA size won't be enlarged. So LA size will not reflect the LA pressures, because LA pressures, when are chronically elevated, like in chronic MR, then only you will get larger volume. LA size is large, LA volume index is large. Got it? Dr. Arif, any comments from you?
I think uh, uh, the case was good, and these are very lot of small things, because infective endocarditis perhaps it comes at the end of after having learned everything, and because the valve dysfunctions will be there, chamber dimensions will be altered, and flow can be from one side to the other side. So you have to be very careful with the assessment of all the possible complications of the infective endocarditis. I think she has presented a quite comprehensive and good case.
Yeah. Dr. Agrawal, you are here. Any comments?
Madam, already discussed we have.
All right. Okay. So you have another case, Sangeeta?
Yes, ma'am.
Please go ahead with that.
Yeah. The second case, actually, it's a small one rather, but very important in day-to-day practice,
Okay.
So the second case is of a patient, 52-year-old male, and he is a known case of chronic renal failure, and he was on hemodialysis. And this patient is presented with progressive DOE NYH class 3, and his so echo, he came to us for echo. Now his echo was performed. I would mainly like to just emphasize more on echocardiography. If you see the left, this is the left parasternal view, and the LV, you can see some hypertrophy of the left ventricle, a little bit of MR, the LV function is normal. So usually in CRF patients, we do see LV hypertrophy. The four-chambered view, the heart size looks normal. All the chambers are normal. Biventricular function is normal. But then you start seeing one this here, the RA. See, a thrombus is seen in the right atrium. The window was not very good. But then there was this structure here which was seen, and we were like, okay, what is this? And so we were trying to look it carefully by zooming it and all that. But of course, the window was not very good. So we had to put this patient for a transesophageal echo. So now, the transesophageal echo, this is RA, LA, the ventricles, LV. This is the level, LV, LA. Now you see that this is the intra-atrial septum, LA, RA. And a huge, so you can see this huge thrombus there. Now, if you see carefully, this thrombus is not attached to the intra-atrial septum. So we have ruled out LM myxoma. And now this thrombus, if you see, you can see the catheter, POMA cath coming here in. At the tip of the POMA cath, you see the large thrombus there. Thrombus. So if you see, it is not attached to the RA free wall. And you can see the POMA cath coming from the SVC. This is the POMA cath here. You can see that tubular structure. And at the tip of that, you can see the huge thrombus in the right
use the
atrium.
pointer, correct?
Yeah. So you can
Because
see
the
this. This is the
image is
POMA
not
cath.
very good.
And this is actually the huge thrombus here. That's the thrombus. The interatrial septum is clear. It is not attached to the interatrial septum. See, now in this view, it is seen very nicely. You see that is a tubular structure and a huge thrombus here. Is it seen clearly, ma'am?
Yeah, it is
Now?
clear, but a little better because
That
I
is
don't know,
the
I'm
catheter
feeling as
here
if everything is
in the
blurred.
SVC.
Mm-hmm.
Is it? Okay. My internet connection is not very good. Somehow,
Yeah,
something is happening. Maybe because of that, it is blurred.
correct.
But
I'm
if you
as
see
if
now, the tricuspid valve is also clear. It is not attached to the tricuspid valve also. That is the permacath catheter. Okay, ma'am.
all right. Okay. Okay.
So now differential diagnosis first is RA myxoma, like which we ruled out because it is not attached to interatrial septum. Infective endocarditis, of course, this mass, whatever, it didn't look like a vegetation. And this is a RA thrombus, mainly catheter-related thrombosis, common in long-term dialysis patients. And this can cause pulmonary embolisms or obstruction sometimes to the tricuspid valve, or it can be a tumor also. So now patient, whenever we see like this clots in the right atrium, usually we think of permacath, thrombosis. So patient has to be anticoagulated. And so this patient was anticoagulated with IV heparin was administered in view of CKD patients. And I do not have actually the post anticoagulation echo, but this thrombus completely disappeared. And then this catheter was taken out. So the take-home message is anticoagulation is needed in such cases, and never remove the catheter before anticoagulation because there will be high chance of embolism. So first anticoagulation, a repeat echo to check for the thrombus, and then just, the catheter was taken out. Thank you, ma'am.
Yeah. Okay. Some few points, I hope those who don't know what permacath is, permacath is a permanent catheter which is introduced from the internal jugular vein into the through the SVC into at the tip of the RA for dialysis, right? Either you are waiting for an AV fistula or you have some issues with the AV fistula, then this permacath is used in dialysis patients. So first of all, we know it's a CKD patient, it's a prothrombotic state. CKD patients as such have a prothrombotic state. Then you have a catheter. Any catheter anywhere for prolonged duration is prone to clot formation. So the moment you see that there is a patient with permacath, you are doing an echo, you are finding an RA mass, think the possibility of, and if you're finding that mass at the tip of the catheter, so right at the mouth of the catheter, so it is highly likely that it is a catheter related clot. Of course, Sangeeta has told very nicely that other things are also to be kept in mind. But this is the first thing that should come to your mind, the catheter related RA mass, RA thrombus. And most likely it is a thrombus. Okay, so if it is very mobile, highly mobile, do not take out the permacath just like that. Anticoagulate the patient very well. If it is a very small mass, a sessile mass, meaning not looking very, very mobile, because mobility means embolism. Embolism means pulmonary goes to lungs directly. So in such cases, you need to anticoagulate them first and then remove the catheter and go ahead for the AV fistula for the further dialysis. So this is a very nice case. One should, while we are doing echoes in the critical care or in the routine OPDs, a patient coming like this, this should be in your mind. So that was the reason behind showing you this case. Dr. Arif, your comments?
My comments are that the images are pretty good, and I think I will be also showing one of the case of this thrombus in the RA at the tip of the permacath,
Very
and
good.
I'll be discussing a few things then. So I'll
Okay.
just hold on for the time being.
Okay. Okay. Dr. Madhu, you have any suggestions?
No, Dr. Hansa, I think you've covered everything. Thank you.
All right. All right. Thank you. So, Sangeeta, do you have anything else, or we move on to Dr. Arif?
Yes, ma'am. Yes, ma'am. We can move on. Thank you,
Okay.
ma'am. Thank you,
Yeah.
everybody.
Thank you, Sangeeta. Thank you for
Thank you.
taking all the efforts to show us these good cases. They
Yeah,
are
thank
of clinical value and one should keep it in mind while doing the echoes. Thank you once
Yes.
again. Thank you.
Thank-
Arif, over to you.
Thank you, ma'am.
And I'm gonna show you a quiz. Okay, so keep learning what we are teaching. Of course, I'm not, promising any prize over that, but let's see.
So can you see my slide show
Yes,
now?
yes, yes,
Okay.
yes.
Okay. So I'll just be starting.
Yeah.
So the title I have given to this is cardiovascular infection, and let me just emphasize here on this topic itself, because earlier we used to use the word endocarditis or infective endocarditis, suggesting that the infection was there on the inner lining of the heart, whether it's the valves most of the time. Now there are so many things inside the heart, and so we have to remember this, that we may be getting something else also. So not just in the heart itself. Can anybody tell me why my slides are not moving? Just a second. Okay, so can you see the next slide now?
Yeah. Yes.
Okay,
Visible.
so this cardiovascular infection, now we expand our understanding and the categories into the what we used to call as the infective endocarditis, which was the infection in the endocardium and specifically involving the valves. Then cardiovascular implantable electronic devices infection. So we see a lot of devices now, whether it's pacemakers or it's ICDs. So these are the electronic implantable devices. And then we have left ventricular assist devices, which can also get infected. And then we all know that coronary stents, every now and then we keep seeing the patients get implanted with these stents. And there are situations when these stents also can get infected. So these are some of the different scenarios. And each time, whenever we are seeing these patients, so obviously, whenever we are talking about the infective endocarditis, the first question is, what is your clinical suspicion? So if you have a high suspicion index, and you think there is a possibility of infection in the heart, then we have to evaluate the cardiac structures. And it is very important that when you are doing the echo, you have to be specifically looking at different areas. So if there is any implantable leads are there, you have to focus on the leads. If you have any pacemaker device, look at what is happening there. Ventricular assist device, those are not very common, but they still can get infected. And native valves, obviously, they are prone to infection, especially there are certain type of bacteria which can be there if the patient has got a history of drug abuse. They can also come with the history of long fever. And these days, if we go back about a decade, then initially, Dr. Hansa will remember this, that when we used to work in Scots, then the number of vegetations and the infective endocarditis cases that we used to see was not very high. Once in a like 3-4 days, we will get a case of infective endocarditis. But nowadays, the number has gone up very high. Almost every day, 3-4 cases I'm seeing these days. And the reason is that the patients who are surviving in the scenario of cancer, then renal failure, liver failure, and liver transplant, and various other situations. So, where there is immunosuppression for one or the other reason, and these patients are surviving into a situation where the immunity is quite low, and so they are quite vulnerable to get infected. So it is very, very important that you have to have a background story of the patient, because a lot of time what happens in the real scenario, that one of the your colleague technician has put the patient on the table, and you just come and start doing the case. So unless and until you are suspecting, and you know we have to search for these vegetations, you may not pick it up, and we may miss the diagnosis of these infections in the heart. So going into the history is very, very important. And then once we have the history, because whenever we are suspecting infective endocarditis, so once the clinical scenario suggests that there is a possibility of infection, so now one is that presence or absence of infection, there are structures which are suggestive of vegetations inside the heart. Now the next question comes, whether these vegetations have damaged the valves to an extent that they result in dysfunction of the valve. So sometimes they just result in the regurgitation, and sometimes they result in perforation of the valves also. And then there are situations where, especially the aortic valve, they can cause a root abscess. The surrounding area of the aortic valve, the annular region, it can get infected. And similarly, in the prosthetic heart valve situations, the similar thing can happen. The valves can get infected, and the peri-root abscess can form there. And sometimes these infections, they can burrow deep inside the septum, or they may rupture from the root of the aorta. And there it is very, very important, because if there is a rupture at the aortic root level, it's a very dangerous situation. And even if the patient is going for surgery, so if we have seen that the valve is the aortic root is getting infected, then the implication in the surgery are very important, because then the aortic root also has to be replaced, not just the valve. So all these things are very important from the clinical perspective. And so whenever we are starting, we must have all this background story, and we have to diagnose whether the vegetations are there or not. Once we have seen that the vegetations are there, what is the impact of them in the valvular dysfunction? And obviously then there are lots of other things. So as I will discuss the cases, I will just be talking to you about each scenario, what we have to specifically look for. So this is a patient who has got bicuspid aortic valve, and you can see in the center there is a. Can you see my this pointer?
No, Arif. Now it's seen. It's seen.
Okay.
Yeah, it's seen.
So, okay, so I'm just pointing at this in the center, there is a valve, aortic valve. This is a transesophageal image. And if you can see on the upper portion, this is transesophageal and this mid-esophageal position. And this is at 74 degrees. So in this view, what you are seeing is the aortic valve in the center. And we can see the opening here is a bicuspid aortic valve. And these bicuspid aortic valve, they are not like a normal tricuspid aortic valve, and there are some minor injuries to them during the lifetime. And depending on various scenarios, they may get, obviously they get stenosis also, and because of stenosis there is turbulence going on, so their surface is vulnerable to get infected. And so this patient gave a history of fever running for some time. Now you can see in this particular image that this is the mitral valve on this side, left atrium on the upper portion, left ventricle is down here, and this is the aorta here. And these are the aortic valves. And you, if you see it carefully, this is a there is a flagellar structure which is mobile, moving to and fro. Once it is like with the valve going into the LVOT and the aorta side also. And so this is a case which if you find this sort of a structure, so this with the background of fever with culture positives, we have to give a diagnosis of with like the flagellar structure at the aortic valve, and the size of this we have to mention, and we have to say this is possible infective endocarditis. Now you can have similar picture in a person with a blood culture positive situation, and then you can have the similar situations where the culture may be negative, and culture negativity can come because of various reasons. One of the commonest reason for a culture negative situation is partially treated. Patient has taken antibiotics for the fever, and the culture has become negative. And then there is a group of culture negative endocarditis, and so there are a couple of things. And then there are rheumatological situations where you can have non-bacterial endocarditis like this. So diagnosing these patients, we have to be very sure that we don't miss on anything. Now, when we are talking of this aortic valve has got infection, we have to make sure that what is the level of aortic regurgitation here. And so you can see there is a quite
Please mute
significant.
yourself. Somebody is talking. Unmuted. Please mute yourself. Do not disturb us. Arif, I'm muting everyone.
Yes.
You again unmute yourself. Okay, I'm just muting everyone.
Okay.
So I think you are muted and now you unmute yourself. Arif, unmute yourself.
Okay. So I have done it.
Yeah.
Okay. So I'll just go into the. Okay. So you can see the aortic valve has got this. There is this quite lot of aortic regurgitation, and this regurgitation, if you see, this is taking a path where it is hitting the AML, anterior mitral leaflet. And there is a very small amount of mitral regurgitation also, which is insignificant, but this aortic regurgitation is quite a bit here. So we now have seen that bicuspid aortic valve, there is no significant aortic stenosis component at the moment, and we are seeing a lot of regurgitation going on. And as we know in the guidelines of management of the patients with aortic regurgitation, we know the LV dimensions are very important. So we have to understand that we must see whether what is the dimensions of the left ventricle in this particular scenario. And so I have just gone back to my previous slide, and again I'm showing this, that we can see the AML here. I just want everybody to understand this AML, this jet from the my aortic valve is hitting the AML, and so this mitral opening also gets restricted because of this phenomena, and it can produce a diastolic murmur, and there is a name for that murmur which I will not tell you now. Dr. Hansa might ask you that question in the quiz.
Okay.
And if even if she doesn't ask you, I would like you to go back and find out what is the name of that murmur which is produced in aortic regurgitation from the mitral valve. So see very carefully, and here we can see that the LV dimensions are fine right now. And so in this scenario, if we are finding significant aortic regurgitation, we should start the treatment as soon as possible, and keep following it up regular basis. If the patient is clinically and hemodynamically stable, we should continue and complete the treatment before planning or assessing this patient for possible aortic regurgitation surgical treatment, because even if it reaches the level of severe aortic regurgitation, even at that point, the dimensions of the LV are very important to understand. And if the patient is able to tolerate it and hemodynamically patient is stable, these patients are managed conservatively as long as possible. So now because I have collection of cases, so I'll just move from one to the other cases, because I just want to
Yeah, I
take
think
the
that will
opportunity.
be good.
Yes.
That
So this is mitral valve infective endocarditis, and so this is again a transesophageal echo image. This is at the 0 degree. If you see here, you can see all the four chambers here, and this is the left atrium, right atrium, left ventricle, right ventricle. There is a tricuspid valve, mitral valve is here, interatrial septum, and the interventricular septum. You can see the mitral, this left ventricle is contracting quite well, as well as the right ventricle. So apparently other things are fine, but if you look at the mitral valve, so these are two leaflets we can see on the mitral. There is a one coming from the septum part. This is anterior mitral leaflet. The other coming from the lateral aspect. This is the posterior mitral leaflet. And if you see, there is a big chunk of mobile structure here, which is moving with the valve to and fro. And this is a very classical picture image of a vegetation. So this patient again had fever and culture positivity, and so we were suspecting that there is going to be a clot here, this infective endocarditis in this scenario. And if you see carefully, then you can see this valve, this vegetation here. This is resulting in non-coaptation of the valve, and so you start suspecting that this presence of vegetation here will result in valve dysfunction, especially the non-coapting part. And this is a zoomed image. You can see there is a main globular structure, and then there is a mobile component as well. If you see higher up, it just comes and goes. Now, at this point of time, there is something very important to understand, that you see this image. So this is an image, and there is something by the name what we call as frame rate. And this is a very, very important concept to understand, that we must know what is frame rate and what is the importance, why we should be talking of frame rate in a patient with vegetation. So because these vegetations, they are very mobile structure and they are moving very fast. So unless and until you have a good frame rate, you may not see them. This one was quite big, so we are able to see. So if you see on this side, left upper screen, you can see that there is something written as 33 hertz. So we are seeing this, but at times when we are not able to see it as good, then what we do, we try to decrease the screen area. And when we decrease the screen area, then the frame rate goes up. So if you can see now with this zoomed image, we are able to see the frame rate has gone up to 66. And you can see these things in a better definition. You can see part of it, the mobile component, which is on the back side also. So the resolution becomes better, and at times when we are not able to see things, otherwise we are able to see here. And so otherwise also, even if here you can see when in the systole, sorry, in the diastole, when the leaflets are opening up, it is coming here and you can see the whole chunk of infective component. So this is very important that we reduce the size of the sector to see the details of the structure. Now you can see the regurgitation coming from this. And as I was mentioning in the previous slide, so if you see this slide carefully, and if you see the two leaflets, the anterior mitral leaflet and the posterior mitral leaflet, they are, because of this vegetation, this is moving in. So there is a prolapse of PML going on at this point because of this vegetation. And this non-cooptation, as Dr. Hansa was in the last presentation asking you, that if the PML is prolapsing, where will the jet go? So one, this there is a non-coopting area now in this area here. You can see clearly. So when we talk of the frame rate, this is the quality of the machine. And so each machine has got its own frame rates. The better machine will have better frame rates. And we then make the sector area small and we increase the frame rate. But at the same time, there is something I usually say, that the frame rate of the person who is doing the echo, because your eyes also have to be trained to pick up these things. And unless and until your mind knows what you are looking at, so you will not see this. So you have to be very carefully watching this. Now you can again see there is an area where there is no non-cooptation between the, so cooptation is a problem, and when there is these leaflets are not coopting, the jet will go like this, and this is what you see here. So the jet is traveling like this along the AML and then along the interatrial septum. Part of the jet is also going into the central area, but there is a definite jet which is going all the way that side. So I'm just, you can see this here. I have frozen this. So this jet is going all along the interatrial septum. And again, now I have zoomed it. And again, it's just the frame rate thing that gives you more better definition, and you are able to see there's a huge mitral regurgitation going on in this patient. So you have to be careful and specifically search for these things, because if there is so much of mitral regurgitation going on, patient may land up in, because this is going to be an acute mitral regurgitation, not a chronic mitral regurgitation, and patient will go into heart failure. Now we move to the third case where I'm just showing you it's a native aortic valve infective endocarditis with an aortic root abscess. So now you see this. This is a very interesting case. This is a transthoracic image, parasternal long axis, and you can see the aorta is here, aortic valve is here. This is the interventricular septum, posterior wall, left ventricle, left atrium, anterior mitral leaflet, and posterior mitral leaflet, and the RV is there. Now, when you look at this aortic valve, you can see a large chunk at the aortic valve, which is again moving to and fro. And so this is when, as a clinician, if you are doing an echo, you will get scared to see this because you are just worried that this should not fly off. And then you put a color here, and then you see this flow is going from here. There's aortic regurgitation going on. But when you zoom it and you specifically look at this image, so again, your mind has to know that there is a possibility of aortic root abscess in these scenarios, and so you must suspect. Now I have frozen this. This is an image. This black structure, you don't see it like this. If you are seeing this, it means there is an abscess formation at the aortic root level. Just this is the septum region here. So at the root of the septum and aortic root, in the starting point of the interventricular septum, this big cavity is there, and so this cavity becomes apparent, and then as the patient is breathing, so the image keeps moving from one phase to the other phase. So now once you have seen this aortic root abscess is there, so now these are very difficult patients and very dangerous situation, because you have to remove the aortic valve, you also have to replace the ascending aorta, and you have to take care of the starting point of the interventricular septum, so that also needs to be repaired. So this is a case where a lot of implications are there. Now
And
this
the
is
AV
short
node,
axis.
AV node will also get
Yes.
compromised.
So aortic node, AV node can get affected, and the patient can go into the complete heart block.
Complete heart block.
So that is another patient after this I'm going to show. And this aortic valve, you can see in the short axis also there is, and the abscess that I was just mentioning is yes. So you can see here at the 11 o'clock position, you can see there is a small cavity present here. So right now this is a cavity still contained. I'm not seeing any regurgitation from this into the surrounding structures. But if this gets affected, then aortic root can get ruptured. One of the sinuses can rupture, and it may produce a ruptured sinus of Valsalva also. So you have to keep thinking all those possibilities. And this is a very difficult situation, even for a surgeon, because they have to repair this. And if you can see, because of this infective process, there is some bit of pericardial effusion has also collected all around the heart. You can see again in the 5 chamber also this vegetation, and this apical 3 chamber view also you can see. And this is a descending thoracic aorta, and in this image also you can see during the diastole this red color is persisting there, which is an indication that there is a regurgitation This flow reversal is there in the descending thoracic aorta, and which is lasting almost the whole of the diastole, what you call as the holodiastolic flow reversal in descending thoracic aorta, which is a marker of severe aortic regurgitation. So this patient has got reached the stage of severe AR. So as I was earlier mentioning that are these patients are very important patients, and especially from the evaluation perspective, from the echocardiography perspective, infective endocarditis is area where you have to know the whole of the imaging echocardiography, and only then you will be able to do justice to these patients. Because again, I will just emphasize that identifying these structures of infection, followed by their hemodynamic impact and the anatomical impact, we have to see everything. Now here what you are seeing is the hemodynamic impact of the aortic regurgitation, and anatomical structure abnormalities I have just shown you. So there are lots of things that you have. Now this is an M mode across the descending thoracic aorta, and you can see this is the QRS here in the ECG, and so this is the diastole here. Whole diastole is filled with red color. So this is another proof that this regurgitation is going on throughout the diastole, and this again is one of the criteria for diagnosing these cases as severe AR. Now this is
Arif, I
Yes,
think this,
ma'am.
just make this as the last case, then I'll take 10 minutes for the quiz
Okay.
and we'll need to wind up. है
So
ना?
you want one more case, or
Yeah, I think this,
okay.
if you can be a little quick in
Yeah,
this,
okay,
show them
okay,
the image, and we
okay,
will continue in the
okay,
next,
because this is just the same thing, but there is a prosthetic valve.
yeah.
Okay, so this is another patient who has got aortic valve prosthesis here. We can see the aortic valve prosthesis is here. This is the short axis view of the aortic valve. Again, if you see carefully surrounding the aortic rim, the prosthetic valve ring, there are small cavities, and this is from almost 8 o'clock to 12 o'clock, and then extending up to the 3 o'clock position. There is black structure. The So we have to be very careful. And now if you see this image, there is a blood flow, because normally you can still find that sort of an image, but no blood should be coming from there. But if you see in these images, there is a blood regurgitation going on from this. So there is a formation of aortic root abscess, and there is a regurgitation going on from there. And this is a transesophageal image, and you can see this aortic valve, the attachment on this side, this is moving to and fro. This is known as the rocking movement of the aortic valve. This shows that the valve attachment on this side has got broken. This either is loose, or because of infection, this area has given up. And you can see there is a little gap here. So the blood is flowing from aorta into this space, and then going into the left ventricle outflow. So rather than, actually there should not be any regurgitation, but now the blood is going back into this from this. And that you can see in this image, that this is the path which is taken here. So there is a aortic root abscess, and there is a severe aortic regurgitation in this patient. This is a 3D image. So I'll stop at this point.
Yeah,
And
and we will continue it next time also.
yes.
But Dr. Arif, they were wonderful cases. And what message I think, I also derived, and I would again like to, summarize that for my audience, is that just finding a vegetation should not be enough. We are like, happy, oh, we got something, the patient has fever. It is, you have to complete the whole workup, in the sense that you need to figure out, is there any abscess, is there any regurgitation? If the regurgitation is there, what extent of regurgitation is there, what kind of vegetations are there, And like he has shown that in the aorta, you could also see the holodiastolic flow, which is a very good sign of severe AR, and generally not very well seen. So here you could see another finding, which will help you. He has put an M mode on the descending aorta after putting the color, and then he interrogated it along with the ECG, showing that this is systole and this is the diastole, and you're finding that throughout the diastole there has been a reversal of flow because there was a torrential AR. So then only your entire workup is complete. So just looking at the vegetation or a mass doesn't help. We need to work out completely that what kind of masses, and anything which is very, very mobile is a high risk. As he said that, it may fly away anytime. Flying away means a stroke for sure. So if the mobility is too enormous, one should be reporting that, so that, and anyways, such are hemodynamically compromised patients, so they should be quickly taken for a surgery. Am I right, Dr. Arif?
Yes, ma'am.
Yeah. So I think I'll quickly take a quiz for them. Let's see,
Okay.
because there are, you have, I think, closed your this thing. I'm
Yes.
sharing now.
Yes, I have closed.
Yeah. So my slide is seen. Can you
No,
see my?
madam.
Not
No?
yet.
No.
Okay. Just a moment. What happened? Wait. Share. Is it seen?
Yes.
Okay. Let me. Yeah, it's not coming full. Just a second, yeah. Okay, is it seen? Can you see it?
Yes, ma'am. Yes.
Yes, ma'am.
All
Yes, ma'am.
right. So you can write in the chat box, which is not useful in assessing LA pressure in acute MR. Okay, what is not useful while you are assessing an acute MR? Is it MR jet contour, the TR velocity, the pulmonary venous Doppler, or the LA volume index? You can write in the chat. Dr. Arif, can you just see the chat?
I can see the chat.
So what are they answering generally?
Austin Flint last,
Austin Flint, right?
and then Austin Flint, then somebody written last one, LA volume index.
So majority are writing LA volume index, right?
Yes.
Yeah. They are
Somebody written
learned people.
MRZ contour and
Yeah.
volume index. I
So
think majority LA volume index is what.
So the right answer is LA volume index. LA volume index actually, it will get enlarged only in a chronic case. In an acute case, it will not show anything. So it's an index of chronicity. Okay, and even when the LA pressures, they become normal, the volume index stays high for some time. So that is not the right thing. What happens in the pulmonary venous Doppler when the LA pressures are high and there is an acute MR? There you may start finding blunting of the S wave. I'll show you, I think I have a diagram. So there is a blunting of S, and there are two waves, S and D waves. So the systolic wave starts blunting down, and there is a systolic reversal, which is seen in severe MR while you interrogate the pulmonary venous Doppler. Is that clear, everyone? So so the next question is, the patient has severe dyspnea, pulmonary edema, and mild cardiomegaly. This is suggestive of chronic MR, primary lung pathology, HFpEF, or acute MR with sudden LA pressure rise. You can write A, B, C, D.
So somebody has written D,
Hmm.
acute MR, sudden pressure rise, D. Everybody, I think, chronic.
Oh.
Somebody now is writing chronic MR.
Hmm.
So I think majority of them are
Majority are right.
for D only.
Okay, good. So I told you my audience is very learned. So, so this is the right answer. Acute MR with sudden LA pressure rise. Why? Because uh, it is unable, the lungs and the LA, no one is able to compensate for it. Okay, and the heart is not enlarging because it is an acute MR due to some reason. So there's a sudden pressure rise, which Sangeeta has shown you, that why it is now, reflecting back into the lung and RA, and then you are getting a TR. So this is a situation of acute MR with sudden LA pressure rise, and the heart is not able to compensate for that. So my next question is, acute MR with high LA pressure typically shows which pattern of Doppler, echo Doppler? Acute MR with high LA pressure. What kind of Doppler trace you will find?
So answer is coming as C.
Hmm.
Now
सब intelligent लोग हैं यार.
maybe majority
Okay.
are going for C only.
Ha, so that's the right answer. And so since the pressure, the LA pressures have suddenly gone, so there is a, early peaking, meaning the equalization of pressures are happening early. Okay, and there is a sudden deacceleration also. So it is a kind of triangular pattern which you are getting. And so this dense late peaking jet is generally a chronic MR. All right,
Yes.
and low, why is there a low velocity? Low velocity faint jet meaning a mild MR. Okay, so that cannot be in the such kind of situations where the LA pressures are high. LA pressures will go high only when the MR is very acute and severe. Am I right, Arya?
Yes, ma'am.
है ना? So this is early peaking triangular jet will also, that is why I was asking Sangeeta that do you have any Doppler trace of your case which will help us to differentiate that this is an acute MR or a chronic MR. So sometimes when the patient is unstable, you are not able to properly do your study, entire study. But yes, these are parameters which wherein you will join the dots and you will come to know that what are you dealing with. So keep in mind that it is an early peaking triangular jet because of the early equalization of the LV and LA pressures. The LA pressures suddenly go high.
Yes.
My next question, okay, yeah, this is the one which I was trying to see this. You can see my pointer. Arif, is my
Yes.
pointer visible?
Yes, visible.
So see the pointer, this is the early triangular jet, early peak velocity, dense triangular contour. See this? है ना? And see, this is a central jet. Now, this is the pulmonary vein flow pattern, the systolic wave, the diastolic wave, atrial reversal. What is happening here in severe MR? The systolic reversal happens very categorically, if categorical and specific if you get it. So indicative of severe MR. This is the diastolic wave. So before that, the systolic reversal takes place. See what is happening here. The leaflet has become flail and is, bouncing back in the LA. See here, this chordae has got ruptured. This is the papillary muscle. Only one of the chordae has ruptured and the this mitral leaflet has Anterior mitral leaflet has become flail. So now see what is happening. It has become flail. How is this jet going? Eccentrically.
Eccentric.
है ना? So it is hitting this wall posteriorly. Okay, so these things should warn you that, okay, something is going wrong with the AML. If PML would collapse, then it will go like this, right? So looking at the jet eccentricity also gives you an answer. And these kind of, ruptured cordes are seen floating in the LV. You should be carefully looking for that. And sometimes this papillary muscle also gets avulsed whenever there is a infarction and this area undergoes a severe necrosis. So a hampered systolic function also indicates you this, or during acute chest trauma, this can get avulsed. So you can get an acute MR patient becoming dyspneic. So this should come to your mind. This is a chronic compensated MR. See, now that there is time for the LV to adapt. So what is happening? It is enlarging. It has enlarged. There is an eccentric LVH. It has enlarged. The end diastolic volumes have increased, and hence the forward stroke volume, despite of regurgitation, it is normal. So this is a compensated MR. The LA pressures have normalized. LA has now dilated, and the pulmonary congestion has relieved because of this dilatation. So this was just out of the blue. I got this image and I thought it is good to understand the pathophysiology. My next question is, a patient of inferior wall MI develops a systolic murmur on third day. What is not possible? Papillary muscle rupture, ventricular septal defect, ischemic chordae rupture, ASD.
BST.
But ASD is just not possible.
So I think everybody is
Yeah, this is a very
aware
easy
of this
question.
question.
Yeah.
Everybody is writing
Yeah.
D.
Yes. So this is very easy. Okay, now my next. So why I'm saying this is, you are in the critical care units, ICUs. You must keep all this in your mind, that this all can lead to MR, severe MR. What is the most common cause of spontaneous chordae rupture in elderly patient? Rheumatic, infective endocarditis, myxomatic degeneration, trauma. Sangeeta has told you this.
C.
So everyone is for C?
Yes, everybody is
Good,
getting C only.
good. Okay, a mass is detected within 3 months of valve implantation, causing, meaning this is a case of prosthetic heart valve. And what is the most likely diagnosis? Understand this 3 months. This is a clue. What is most likely? Easy,
So
very
they are
easy.
saying divided between B and C.
Acha, B and C.
Yes.
C.
So
Yeah,
either
B.
thrombus or vegetation.
Yeah. So I'm not giving any history of fever. All right. And
Thrombus.
yeah, thrombus is most likely.
Thrombus मैंने बोला.
So whenever it is a chronic thing, after say 12 months, the pannus is always chronic. So always think about that, in the early stages, it is generally a thrombus which you are dealing. Patient's INR is important. Patient's fever history is important. Okay, anything else, Arif? Then, there are a lot of things to differentiate.
Yes.
Yeah. So just trying to tell that early mass on a PHV is usually a thrombus. Usually a thrombus. If you will diagnose it as a thrombus, you will be 90% times right.
Yes.
Yeah. So my next question is, yeah, a frond-like small pedunculated mobile mass. Arif, next time you have to show this.
Okay.
ठीक है ना? C anemone appearance on the aortic valve, most likely diagnosis. A frond-like small pedunculated mobile mass. C anemone, अभी दिखाऊंगी what is C anemone. On the aortic valve, most likely diagnosis is
So they are writing D.
D.
Yes.
Audience, think again.
C. C.
अब ये दिखा? See this? This is a C anemone animal. And the fronds. So this is a very classical papillary fibroelastoma. All right. Never forget it. Okay. Tiny, thin, filamentous, linear structures with a line of valve closure. Likely diagnosis: small vegetation, thrombus, Lambel's excrescences, NBTE, non-bacterial thrombotic endocarditis.
So I think here everybody has written C.
Very good. So this is your clue at the line of valve closure. Okay. So whenever you are seeing it and you're making a opening in a three-dimensional view, you see that they are at the ends of the valve. Okay. So you should think about this. These are also filamentous linear structures. So Dr. Arif will show you this next time. So last question, broad base, small vegetations present on both sides of the leaflet, minimal valve destruction. I have just summarized here all the most important things which should come into your mind while you're handling patients in a patient of SLE. So minimal valve destruction, okay, and broad base,
This is
small
C.
vegetation.
C. Melantic endocarditis.
So what is rest of the public
Melantic
saying?
endocarditis. C.
B. Liebman Sachs endocarditis.
That means
क्या हुआ बंधुओं?
I think on this question there's a lot of division. A, B, C, D, I think all options they have given.
Yeah. तो नहीं आ रहा.
Screen, I think your screen,
Sure.
somebody, I think just
Screen.
click to
Acha,
upgrade.
just a second. I think what went wrong?
नहीं सुनाई दे रहा
C हम लिखना चाह रहे हैं.
यहाँ से लिखिए ये है
इसको आगे बढ़.
आगे कर दीजिए
I think screen sharing
चला
off
गया
करेंगे तो ये चला जाएगा.
अच्छा, एक मिनट, पता ही क्यों नहीं हो रहा है.
कहते हैं क्यों नहीं हो रहा. क्यों नहीं हो रहा. उनका क्यों नहीं हो रहा.
अच्छा, लिबमैन सैक है उसका आंसर ना. इट्स आंसर इज
Okay.
एक मिनट.
बंद करो.
Anyways, I was about to be. Nothing is happening. Generally in SLE we get Libman sac endocarditis. ठीक है? So next time Dr. Arif is promising us to show all this on all the cases related to this. ठीक है Arif?
Yes, ma'am.
Okay. So thank you all. I hope everyone has
ma'am,
enjoyed.
I have a question.
Yeah.
What was I actually missed that. What was the mass detected within 3 months of valve implantation?
Thrombus.
How do you differentiate it with TANUS?
So PANIS is generally an inflammatory state, degenerative state. So it is something like a chronic inflammation. All right. So you generally you don't get PANAS at 3 months usually. Okay. Nothing is like, everything can happen here, but nothing is. So most commonly, as I said, it is thrombus. PANAS usually happens around 12 months onwards. Right? So whenever
Okay.
you are diagnosing a PANAS, always think when, the valve is little older.
Yes,
Okay,
once
ma'am.
years
Thank you.
have passed, and this will not be a discrete structure, it will be sort of from the periphery.
Yeah.
It will just encroach and restrict the opening of the valve
It
and
is
result in
along the
increased
ring.
bleedings.
Yeah, along the PHV ring.
Okay, ma'am.
And Dr. Arif rightly said it will be obstructing the movement of the valve leaflets, and it will be seen only in the periphery. Thrombus can be found anywhere on the leaflets. Right?
Right, ma'am. Yes,
Yeah.
ma'am.
Chalo, so we
Thank you.
conclude.
Yes, ma'am. I think
Ma'am, one more question. What is the difference between Marantic and Libman-Sack endocarditis? I am not aware of it, ma'am.
अच्छा रश्मि जी ये भी आपको बता दिया जाएगा next time. What we will do is we will make a differential of all these kind of endocarditis.
Yes, ma'am.
ठीक है?
Thank you so much, ma'am.
So
Thank you so much, ma'am.
and the background is also important whenever there are malignancies and such kind of chronic debilitating situation and the blood cultures are negative, fever is there, then generally Marantic is there. With SLE you have small masses on either side also of the valve. So this is briefly I'm telling you, but then we'll try to make a tabulated slide for this, which is differentiating all these kind of endocarditis, and I'll try to present it next time.
Thank you so much, ma'am. Highly appreciate it.
Yeah. All right.
Okay, ma'am.
Thank you, everyone. And if there are any questions, you have groups, you can keep floating whatever is coming to your mind. All right. And good night. Thank you, Reena. Thank you, Arif and Sangeeta. And
welcome.
thank you, everyone who keeps helping me out to conduct this session. Great to have you all here. Thank you, lovely
Thank you.
audience. Bye-bye and good night and
Bye-bye.
happy
Good
Holi
night.
in advance. And we meet next time, March end. So happy Holi till that time. Enjoy the colors. Stay happy.
Thank you.
Bye-bye.
Thank you,
Yeah.
ma'am.
Bye.
Thank you.
Good night.
Bye. Good night.
Thank you, ma'am. Good night.
Yeah.